All right, let's go ahead and get started because we've got a lot packed into this webinar today. I want to make sure that we get to cover all the bases. It's great to see you all who have joined us. For those of you who haven't met before, my name's Tom Strong. I'm the National Fund Director of Employer Activation, and I work on the Career Stat program with my colleagues Claudio Mano and Melissa Cleater. I am actually stepping into Melissa's shoes today as she's on PTO. Most of you know her quite well. I'm really excited about the topic we're going to be getting into today, which is about how we in the healthcare industry and those of us who work with healthcare providers can address work, safety, engagement, and inclusion through rapid cycle learning. So as with all of these career stat frontline focused webinars that we've been holding lately, this is a space that is all about learning and sharing best practices, effective practices, building community and connection around that, and ultimately shifting our own practices, shifting our own mindsets, shifting our organizations towards a better way of doing work, a better way of providing healthcare. What we're going to cover today, we're very excited to have our guest speaker, Cooper Linton, who is the Vice President and Director of Retention at Duke HomeCare and Hospice. He's going to speak about how they address nursing turnover through rapid cycle learning process. We also have our close colleague, Carrie Filton, who's the Director of Equipping Workers for Success at the National Fund. She's going to speak after Cooper to talk about how you bring a trauma-informed lens into workforce development and workplace development. And you'll see the connection between her and Cooper's presentations as we go through. We are going to have a separate Q&A for each one of those sections of about 10 minutes because we think there'll be a lot to discuss. And then finally, as time permits, there are some tools and resources that we have at the National Fund that we think may be helpful to those of you who are working on these problems and challenges within your own workplaces. And as with all of our frontline focus sessions, we're going to close with an open discussion for those who want to stay until a half hour past 2 o'clock. We will, depending on how many people we have today, we'll either have breakout rooms or just kind of an open discussion about what we learned today in this room. So just to provide a little bit of quick framing around the discussion today, many of you have probably seen this document before. This is our job design framework for the National Fund. And it's basically how we think about the challenge of designing good jobs for frontline workers, which is, of course, fundamentally the mission of Career Stat as well. We think about it in terms of these 4 pillars, kind of the core elements of a good job, the support services and support practices that help people achieve stability, how we provide opportunity for employees to advance in their careers, and finally, how we empower, engage, and provide agency to employees and hear their voices. And this session is really going to focus on the last of these pillars. And that's part of what we're excited here. You may notice in the middle of the voice pillar, one of the things that we identify with employee voice is having an inclusive, continuous improvement process within your organization so that employees can help really co-design their own workplace and that the challenges that they are struggling with are heard and acted upon. But there's also going to be other elements that you hear about kind of that are tangentially related to this, which have to do with safety on the job, including psychological safety, having to do with fairness and respect, having to do with good communication practices, and even a little bit of how supervisors may be changing their roles in the organization. But I'm going to leave all the details about this to our other presenters today. And first, I'd like to turn it over to Cooper Linton. So I'm going to exit out of sharing my screen. We're going to have a little bit of a do-si-do here, and Cooper will share his slides.
Thanks, Tom. I hope everybody can see this. Does this, everybody seeing pictures of kittens? Okay, perfect. Well, Tom, thanks for the introduction. Thanks for letting me join you and Carrie and the rest of the team today. I have the privilege of working at Duke operating our home-based care programs. So that's for us, home health, hospice, and home infusion. I'll provide a little bit of context for that in a minute. But candidly, this is for us part of a lean journey And lean is not a common practice in home-based care, but we feel like it should be. So we'll just kind of jump right in. We had a massive problem. We had a massive problem with turnover. We didn't have a small problem with turnover in home health. We had a massive one. We had a 75% turnover rate in our RNs. As you can imagine, that created a cascade with other disciplines, most of which were among our frontline workers. They may be aides, they may have been support staff to our patient care staff, but they were all frontline workers who were dealing with this. 6 months after we rolled out these changes, we went from 75% turnover to under 20%. The next year, we dropped down to 18 and change, and we're still, even post-pandemic and post the Great Recession, still hovering in the low 20s in this area. Industry turnover for this position is 32%. Now, the important piece, however, is that turnover is going down now, not just in our home health business line, but we've begun to spread these practices elsewhere. And our turnover has gone down in hospice, it's gone down in our administrative side, it's gone down in our pharmacy. But not just what's gone down, we need to look at other things that came out of that, these positive externalities that came out of it. And that's that it's improved our quality of care and our ability to grow. And it's worked in every single program every time. We have to implement it differently, but the concepts remain the same. A little bit of level set for how our operation works. And I saw we had somebody here, I believe, from Visiting Angels, who's more probably familiar with the visiting staff that we have out in the community. We run, in essence, 3 business lines. We run a home health business line, which is your nursing therapies, aides, social workers that go into private homes. Most of that is Medicare and Medicaid driven, though we're seeing increasing commercial interest, commercial payer interest. Hospice, exactly what you think it is. We have an inpatient hospice facility, which is actually where I'm camped out right now. And we have in-home, it says in hospital, I apologize. We also do the in-hospital, and then we have in-home care. Our home infusion program is includes a compounding pharmacy. For home health and hospice, we cover a very wide ranging area, about 4,400 square miles. For home infusion, we're covering 3 states. That's 128,000 square miles. So our staff is scattered widely. We often act as the pressure relief valve for Duke Health System, meaning we help them decompress acute beds by getting patients out. So if we have turnover, it not only hurts our organization, but it backs patients up into the academic medical center as well. The overall health system, again, to take a look at lean principles in healthcare, that is not unique at all to Duke. In fact, I'd make the argument Duke was a little late to the game looking at lean principles. Excuse me, what we did that was innovative was that these principles have not been well carried out through home-based care. Some companies have instituted the huddle concept, which is a variation on this. But overall, taking the lean principles to the way we think and operate is something that is not common in home-based care. And it's because the argument has been made, you have a highly diverse workforce working in lots of different settings. For us, over 2,000 settings of care on any given day. And there's no standard design for that. You have no ADA compliant area for your staff. And you don't have security staff. You don't have anybody you can call. Our staff are often lone workers. And because of that, the idea is you can't institute these lean principles. Make the argument, because of that, you absolutely should institute these lean principles. We have to have standard work, and it's part of how we protect our frontline workers and protect their time, but also protect their safety. And so anywhere you have people and processes, it seems to me we should be able to institute these ideas. We jumped into this about 4 to 6 months before COVID. We were not good at it yet. We're still needing to get better at it. But what it gave us was a framework for what became an accelerated rapid cycle change, because we were not only dealing with high turnover, but now we had high turnover in a pandemic, and we were doing care in uncontrolled settings, and the fears level just went off the chart. The picture you see in the bottom right, we actually had a facility that told us we were not allowed to set foot in their facility to provide care. We didn't set foot inside their facility. We actually had the patient roll to the window, and those are two nurses using an ultrasound to infuse that patient through the window. They were so afraid of COVID and anybody coming in and out. We found creative ways to solve problems. I want to talk about the hidden P&L, or the silent P&L, but I like the hidden P&L. If we got a monthly turnover bill, if we got an invoice every month for $500,000 or $1 million, suddenly we'd have everybody's attention focused on turnover. But because so many of the costs are hidden, they're baked into lost productivity, lost morale, lost opportunity to capture revenue, wasted orientation time, wasted training time, because you never get that that employee up to productivity. If we got a bill for all those things, we'd suddenly pay attention. And as an organization, if you looked at lost revenue alone, it was almost $18 million. If you looked at annual expenses tied to direct turnover, it was $4.5 million a year. Combined, you're looking at a $22 million financial impact of some sort during the year, and you had our absolute attention. Unfortunately, if we don't get a bill for this, if we did, folks would look at it differently. A lot of this was driven by clinician turnover, burnout, ineffective workflows, and ineffective orientation. We weren't giving people the proper training and onboarding. Duke has a very high acuity patient population, and folks came to us from other organizations who had done home health, done hospice, etc. And they said, oh, we know how to do it. They came here, dealt with a higher acuity patient, and we realized we were not properly preparing our frontline workforce for the unique types of patients that we were treating. Now, interestingly, when we went into trying to understand this, the first answer we got from our leadership was, the problem is our electronic medical record. And it's burdensome and it's cumbersome and it's terrible. And if we got rid of it, turnover would go down. Let me be clear, we still not gotten rid of the terrible, nasty, bad electronic medical record that we use. And I agree, it's terrible. We're changing that this year. But our turnover went down anyway, even though we're on the same electronic medical record. The EMR was the easy excuse, and it's one that let us off the hook for our leadership behaviors and let us off the hook for the way that we were overburdening our staff through creating ineffective workflows. They began to cash out. You can call that, disengaged team members, or you can call it presenteeism, but it's people who said, I'm not connected to the work anymore. And we weren't getting great feedback as leaders. We were too busy trying to solve problems, not listening to our frontline staff and empowering them to solve the problems. And so we weren't supporting them. If we break that down a little bit, and let me be clear, we got into this by doing a rapid cycle improvement. Most people are familiar with that. But we involved our frontline staff. And when I say involved, they were the majority of the people in the room. The problem is getting one or two nurses into the room, counterbalanced by your executive team, is not really, that's token involvement. This needs to be led by your frontline staff. And that means we have to create the psychological safety in the space for them to say, I'm sorry, but the problem is not the EMR, the problem is the way you're laying out the work for us. We had to take ownership of this as leaders, not as our problem to solve, but to frankly recognize we were part of the problem in the first place. So we had to change the way we began to look at leadership. Ineffective workflows, we were just putting too much on the backs of our staff that were non-value added functions. And everything's important. Oh, this needs to be done, and this needs to be done, and it needs to be done this way, and check this box and check that box. And people began to feel that their voices weren't being heard. They were frustrated, and my time doesn't matter. Well, that means we don't respect you. If we don't respect your time as a worker, then we don't really respect you. If we say we respect you, but then we are not respectful of your time, we're lying to you. And so we needed to change the way we looked at engaging with our frontline staff, which meant we had to shift our entire model of leadership from, hey, our job's to do this, your job's to do that. Thus, we have a transaction. Check your bank account every 2 weeks, there'll be money in. We really needed to create a relationship with them that's better and to step into a role of greater servant leadership. That term gets used a lot, but when done properly, it brings down the barriers between leadership and our staff. And it actually changes the roles to where we become the coaches and the supporters. And most of the work is actually led by the staff themselves. So the solutions we came up with were actually driven through our staff. It was their ideas and we captured it for them and helped them implement it. But it meant that we had to spend an awful lot of time building trust. We had to create a space where it's inclusive. Your voice is heard. It doesn't matter what role you are, you have something to add to this. We not only want you to feel like you can give your voice, we need you to, and we're going to come solicit it from you. Where we can, we want consensus. We're not going to ask consensus about whether or not we wear masks when we do medical procedures. Those are basic safety things. But coming to consensus about workflows and the way work is best done is something that we absolutely should be involved in our frontline staffing, because it turns out they know how to do their jobs better than we do, which meant we had to give them the power to do it. When we talk about motivating people, truthfully, when you free them up, create a trusting environment, and empower them, they're already motivated. They want to do a good job and they want to put their ideas out there. You know, we often talk about staff buy-in. Well, we need to get staff's buy-in to make change. I've never had to get buy-in from somebody when it was their idea to begin with. And so when we got our staff doing this work, we didn't have to ask them to buy into it. We had to buy into their solutions, not them buy into ours. We also have a safety focus. When I say safety focus, we have a discussion about patient, staff, and family safety every day. On every patient, it's reviewed. And we actually start safety discussions with new employees within the first 60 minutes of their arrival to our organization. That's the first thing they hear in orientation, besides, where's the restroom? So we really began to shift as leadership from the doers, the people who were supposed to know this industry, know home health, know hospice, know home infusion. We're paid because we know these things, to the coaches who we may have had subject knowledge expertise, but our job was also to become nimble learners in a highly changing environment. The pandemic accelerated that. We created work groups that were doing their working around problems. The team members were doing the work from the front lines. They were the ones that were driving these teams. And it's messy. It's a lot messier than us sitting in a room and telling them what to do, but it's also a lot more effective than us sitting in a room telling them what to do. And so this messiness is actually just what happens when smart people start trying to figure out how to solve problems. And at first it's clunky because nobody's comfortable doing it. And they're trying to trust you, but they don't fully trust you because this is a new skill. And it takes some time to develop that. You can't just walk in the room and say, okay, guys, I need you to trust me and be totally transparent. Doesn't quite work that way. So we had to become much better listeners, much better at being sure we understood what we heard, not assuming that we did, and encouraging people to really deeply lean in. Now, we start every day. This was not part of the rapid cycle improvement. This is how we start every single day with our what we call tier one versus tier one huddles. And our tier one huddles are where we get feedback from our frontline staff. We start our day with the frontline employee. That's what matters most. So we hear from them and we start with issues. You see on the far left side of this, it's a bit of an eye test: patient harm, employee harm. Then we start looking into what is our admission capacity? Do we have any line infections? It depends on which service line you're in and what harms look like. What can we celebrate? Where are we facing challenges? That gets escalated to tier two, which are the managers. whose job is to immediately resource those frontline needs, regardless of what they are. And if that means you need to cancel everything else the rest of the day, do it. Our job is support the frontline folks. So I don't care what you were doing. What you're doing now is to take care of them. The third tier is our executive leadership. And we literally review this from all of our programs. On Tuesday, for example, we reviewed over 2,200 patients and we did it in less than 15 minutes. And it's an aggregated information. People say you can't do that. I can't tell you how to do it, but I can show you. When you show up to one of these meetings, it's done in a very consistent pattern, but it starts with our frontline employees and filters up. And our job is to take that information and support them and escalate their problems for resolution with a great sense of urgency, because it may not feel urgent to us, but we're not the one living with that barrier to getting things done every day. And when staff begin to see us stopping everything else we're doing and focusing on fixing their problem right now, that's where the trust starts getting built. Rapid cycle learning, I'm sure many of you on this team can teach this better than I can, but it's the idea of saying, all right, let's get together and figure out what works and what doesn't and do a constant, rapid, iterative process. We're not afraid to fail, but we're afraid to do nothing. So let's not be rash, but let's move very quickly and do some experimentation. It's applying the scientific method. We seem to underestimate the risk of the status quo and overestimate the risk of change. Meanwhile, our staff are languishing in the status quo. So how do we help them move through this process and begin to process information in a very rapid manner? For us, this meant we had to totally redesign workflows, totally, and get away from the idea that this is the way we're supposed to do it. Start hacking away at anything that our frontline staff were doing that was just frankly wasteful. Get rid of it. It's not making minor changes, it's making major changes, because if what you've got is a 75% turnover, we don't need a 2.5% improvement. We needed something massive. And so we took very aggressive stances in eliminating waste. We invested heavily in orientation. Orientation in home-based care in some organizations ranges from a few days on up to a few weeks, some people 2 or 3 months. For us, it is now common to run a 16 to 20 week orientation. 4 to 5, even longer months of orientation. That is a massive investment in our staff, but they come out of it with individualized training and education now. They're paired with a preceptor who can help coach them through. They're no longer feeling like they're alone. I had employees stop me in the hallway the other day, said, I've been an LPTA, a licensed physical therapy assistant, for 26 years. No one in my entire career has invested in my orientation and training the way you guys have. They feel that from the day they walk in, and we focus on their safety as well, which happens to be a particular concern in home-based care. We began to modify workloads to make sure that we actually understood the work burden and adjusted our staffing accordingly. And there were some expensive decisions we had to make. But remember, there was a $22 million problem. We could afford to make some investments because we were fixing something that was costing us a ton of money. You've got to have leader buy-in in order to do this, but most critical in this is you have to have frontline staff buy-in. You've got to have a way to catalog and track your changes and be able to show staff the progress and improvement, but most importantly, that they can see it and they know it because they're doing it. They're participating and can look over their shoulder and say, hey, look at what we've done and where we've come from. We also need to be able to make decisions quickly and pivot from failure to what do we learn from that? Not who's to blame, but what did we learn from that? And how do we implement change tomorrow? Because we're going to run a new experiment tomorrow and the next day and the next day. And it will iteratively get better, but we're not going to spend a month analyzing it. We're going to implement and change, implement, change. And it requires a very different pace of leadership to the point that we don't even run our traditional executive meetings anymore. We used to have executive meetings every 2 weeks. There were 2 hours every 2 weeks. I can't tell you the last time we had one. We have executive meetings in 15-minute increments, Monday, Wednesday, and Friday, and we do them immediately after the tier 3 meetings, Monday, Wednesday, and Friday, when our staff issues are fresh on our mind. And what we found is by moving to 15-minute executive leadership meetings, we are not even using the full 15 minutes most days. Our response times are faster. Our staff knows that we're handling their issue today. The worst case scenario, day after tomorrow. But the critical piece is they hear that we're making change and they're part of it, and they see us moving at a pace that supports them, which reinstills trust. As opposed to, I told you something, and 2 weeks later you met about it. 2 weeks later you met about it. I've now lived with this problem for a month and you haven't done anything. And so that has been the critical piece of it. I want to come back to this slide. For us, the question was, could we sustain it? And then could we spread it? This slide shows home health RN turnover, but we wanted it to not just be RNs. We wanted it to be every frontline position, every back office position we have. And then we wanted it to go beyond that, to say, okay, spread it to every business unit we have. And that's what we've done. I covered a lot of information. I didn't cover everything in all the slides, but I wanted to leave some time for discussion, Tom, and questions.
Yeah, thank you so much, Cooper. This has been awesome. Before we get into the audience questions, I'd love to ask a question to the audience, which is, how many of you here currently work for an organization where you're already practicing lean in some way? By show of hands, or if you're off screen, just type yes in the chat. So it seems like, a few of you are, but maybe not most. So for those of you who do practice lean, do you think that applying it towards turnover at the employee level and the frontline employee level specifically is something that your organization would consider or is considering right now? Because I think that's part of the power of what we saw in Cooper. When we heard Cooper speak about this a couple months ago originally, we had not heard of this being done specifically around the turnover metric. And I'm curious from you, Cooper, one of the things you shared when you shared the financial impact of this decision is that your organization was able to think about not just kind of the saved cost from turnover, but also the potential lost opportunities. And I'm wondering how was that something you were originally looking for, or you think your team was just open to thinking about it in that way from the get-go?
Well, we talk about lost opportunities, and there's two ways to think about it. Organizations are quick to say, oh, we lost X amount of, we could have booked X number of more patients and we lost X amount of revenue. I'd also like us to think about it that our mission says we're going to care for people. And so every time we're turning somebody down, we're failing the mission, regardless of the payer mix, regardless of whether we would have been profitable or unprofitable on a particular patient encounter. We missed our mission. And I will also say that because our metrics show in this area that we are the highest quality provider, we sat down with our leadership and said, not only are we missing our mission, but we're relegating members of our community to a lower level of care. What does this mean? And we began to look at the data from our competitors and recognizing that patients had a higher risk of readmission if they did not get admitted to us. They had a higher risk of complications, a higher risk of utilizing the emergency department. No one's ever said to me, I want to go to the emergency department. They may be in so much pain in the moment they want to go, but nobody says, hey, I wish I could go by the ED because I really missed the Jello. That's a bad outcome. If you've ever spent a night in the ED, it's miserable. And by the way, the folks that run the ED, they don't want you there either, because most of them are overburdened. And it's the most expensive place we can deliver care. So we began to look at this not just as a failure of revenue, but as a failure of mission and a failure to our communities. The folks that we serve weren't getting from us what they should have been getting. And so our question was, how do we get to yes? Well, we can't grow the organization if 3/4 of our staff are leaving every year. And you can't do it and if you look at the industry average right now for home-based care, it's terrible. I mean, I'm just calling it. Annette?
Yeah, so I have a question. I'm curious. I think it's impressive that you're able to work with issues and solve them within a day. So
Well, some of them, not all of them are one-day problems. Okay. I'd love to tell you what that is.
That's kind of my question, but more to the point of how long did it take you to get to that point where you were being effective and efficient with it? And then on the back end of that, are you documenting those issues so that you already have in place? Maybe, yeah, we had this happen over here, so now we know what to do about it and we can do that better.
So we have several pieces in that. One, these were new muscles for us, and we really botched it up a number of times starting out. It's really easy to say, oh, look at what we did. But to your point, we didn't go from start to, and we got success, and that happened in 48 hours. That this was a months-long implementation. We did training for our staff. We did train the trainers for our staff. We hired a coach to come in and help us. I needed to change the way we ran meetings. I requested a coach to say, teach me to think more lean-like, if you will. And I was inclined to such things, but I wanted somebody who was an expert in it. So we had a coach working with us and asking questions to help us get better at it. People say, well, that's expensive.
Yeah.
Yeah, it is. It's less than 22 million though.
When you say, but cost savings, when you say a coach working with you, was it a diverse team, meaning from different service lines plus leadership?
Yes. So the coaches actually would attend tier 1 and tier 2 meetings and tier 3 meetings. So working with across all lines. And I would say that it took us about 18 months to really start to feel like we weren't doing something clunky. I mean, the first 6 months were, oh my gosh, I felt like we were, I mean, we even sometimes had scripts for like, okay, we're trying to remember what we're doing here and this feels different. And then it's about team accountability. Hey guys, we're trying to solve the problem in the wrong room. Our job is to use the scientific method and take an A3 approach for those of you that have done lean, and you break down the problem into what's your ideal state, what's your current state, and you start working through that. And you can call it something other than lean. I don't care what you call it, but you've got to go through that scientific process to really understand, really deeply understand the causes of your problems. And what happens is our team was always like, okay, we're going to solve this. Well, we're really not going to solve it for them. We need them to solve it. And so you had work groups coming out of it that would attack certain problems. It took us 18 months to get to our groove, and we're continuing to refine it. I don't think we'll ever finish it on that, but we no longer are paying for coaches to come in and do this. We said, okay, it's time to take the training wheels off. We've got to run this on our own. That said, I'll still pick up the phone on occasion and call one of those coaches and go, hey, got stumped, could use a hand. And the more people you have in your organization, the more often those coaches become your colleagues just somewhere else in the company. If you are the size of a Duke or a larger company, it's hard to do that in a smaller company. You may be the coach. And it'd be great if you can go see this done elsewhere. If you can see it done somewhere else, it makes all the difference in the world. Because until you see what right looks like, it's hard to know what you're aiming at.
Were your frontline workers? I'm sorry, Rita.
I'm just curious. Did you get any like kickback from staff initially when you started?
Yeah, absolutely.
That was going to be my question.
We absolutely did. And at first, there's two ways of looking at this. One is you're asking me to now be involved. So first off, do I trust you well enough to really tell you what I think? Because by the way, the last 3 things you've rolled out sucked, and that's why we're having problems today, right? So that's a tough conversation. Other people are like, okay, I'm getting a chance to participate in making this better. The third way of looking at it is, why are you making me do all the work? I thought that's what you managers were here for. Solve this stuff. I'm out here treating patients. And so we had to really talk about how are we going to function as an organization? And solving problems is everybody's job. Everybody's job is to solve problems. And how effective have we really been at fixing your problems? Let's be honest. If we were great at it, you still wouldn't have them. You wouldn't have these problems. We're asking for your help. And so there's a humility that needs to come out of leadership to do this. And if you come into it with any ego, you've got about 6 months before that ego is going to be buried. And it's going to be sadly injured after about 6 days. Because your staff, if you ask your staff to tell you what's going on, they're going to tell you, and they're going to call you on it when you're not living up to it. And that feels terrible, by the way. That's a great motivation not to do that twice.
So we will have more time to ask a few more questions of Cooper towards the end. I do want to take this moment to turn the reins over to Carrie Felton. Carrie, feel free to load up your slides. As they load up, I'm curious, just think about for yourself, folks. We heard something about trauma in Cooper's presentation, even if he didn't use that word directly.
All right, so when Cooper asked if you could see kittens, I just couldn't help myself. I had to add a picture of a cute kitten onto my slides. You guys, it's kind of my thing that a cute animal has to show up in all of my slide decks. It's actually a trauma-informed practice because looking at cute animals activates your kind of serotonin or your oxytocin levels, which can help counteract some of your trauma responses. So here's a cute kitten for y'all. I want to just do a little bit of grounding to get us on the same page about what we're talking about, why we're talking about it. And then I want to make sure to, let me see, have to click a button to get these to come up, to kind of level set around the impact of trauma and toxic stress on your employees, learn some sort of principles to help you think about how you kind of integrate that understanding into some of these process improvements, job quality improvements that you want to implement in your organization, and share an example from our network of another company that's done this. Before we get started, I want to invite y'all to do a quick breathing exercise with me. You can turn your cameras off if you want. You can not do it if you don't want to. But I'm going to leave it to you. It'll take less than a minute. This is 4x4 breathing. So all we do is we inhale, and for a slow inhale for 4 counts, we hold it for 4 counts, exhale for 4 counts, hold it for 4 counts. So we'll do that twice. I'll do it. I invite you to do it with me. Okay, let's go. Inhale, hold, exhale, hold, inhale, hold, exhale, hold. Thank you for doing that. This is a very simple, very quick tool that is helpful for all sorts of reasons to help center. If you're feeling activated or stressed at a job, it helps kind of lower your heart rate and center you, and it feels good. I do this with my kid all the time, and I'm just demonstrating how some of these things I'm going to be talking about today. You hear this word trauma, it feels really big, really hard to kind of solve for people, but it can start with something very simple that takes less than a minute to move toward a more healing environment at work. Also, it's important to kind of normalize talking about our mental health and well-being and things like that, because sometimes it can be, you feel like you're at work and you can't do some of these things because it's too weird or not part of your job. So that's another reason I wanted to invite you all to do that with me, to sort of normalize doing what you need to do to take care of yourself. Really quick. So the National Fund, in 2020, we published a really comprehensive guide called a trauma-informed approach to workforce, to really serve as a resource for employers and workforce development organizations to kind of better understand the impact of toxic stress and trauma on individuals who might be in your programs or your workplaces. It is a really great resource. There's a lot of information and walks you through sort of like what trauma is, how it affects our brains, how it might show up in the workplace. So I'm going to give you just like a super quick snapshot of some of the information that's in this guide. But please, if there's anything that you want to learn more about, access that. It's on our website. I'm sure we can include it in some of our follow-up materials. I'm not going to spend a ton of time defining what trauma is, but I do want to level set a little bit. So let me move so I can see my talking points here. So being in a healthcare setting, you know, understanding like physical and medical trauma is, I probably don't need to explain, but wanted to kind of just level set around what we mean by psychological trauma, which is a life-threatening or perceiving to be life-threatening experience that has a lasting impact on someone's life. We colloquially, when we use the word trauma, or you hear it used in media, that we usually are also including in that toxic stress, which is another related experience. And the reason this presentation is framed around trauma and why our guide is called a trauma-informed approach to workforce and not necessarily, you know, health and well-being more broadly is because traumatic experiences we know have a particular way in which can change our brains in a very particular way that and those adaptations to trauma to survive show up in different ways in the workplace and in our workforce services. So I wanted to make sure that like that was clear, that there is sort of this brain science element to it that I'm not going to go into detail about today, but that is part of why we talk about trauma. And lastly, the National Fund has a perspective around trauma and what it means to be trauma informed and creating a healing space at work. And that is that institutions and systems, as opposed to just kind of saying, okay, yeah, people experience trauma and it's really important that they go and they get the support they need to heal from their trauma. We believe that institutions and systems have a role to play, a really important role to play, and a stake in making sure that any person that walks into their workplace or walks into their program, regardless of what they've experienced in their life before, is stepping into an environment that's not likely to re-traumatize or be a traumatic itself. So that's why we're talking about it in the context of this series and in the context of, you know, kind of everything that Cooper said about how they've approached, you know, centering their employees to improve the jobs. I hope that this information we share with you kind of can help bolster that and provide another lens to help you think about process improvements at your jobs. And lastly, a really important point that's important to us at the National Fund is that trauma is really prevalent. So there's a robust body of research that shows experiences of trauma are common. The landmark trauma study, the ACEs study, which is studied adverse childhood experiences of over 17,000 patients at Kaiser Permanente in Southern California, showed that over 2/3 of their patients had experienced in childhood at least one adverse childhood experience, and nearly 13% experienced 4 or more adverse childhood experiences, which is like 1 in 10. So that's just kind of one study, one example, and that was looking at childhood experiences. It wasn't talking about other kinds of experiences you might have after childhood. So just a helpful lens to think about your staff and thinking about like how many of your staff might be experiencing lots of challenging things or impacts from past trauma. And at the same time, we know that many of the conditions in the world that increase the likelihood of being exposed to trauma, things like housing instability, involvement with the criminal legal system, gender-based violence, poverty, needing to seek asylum from your country of origin, all of these sort of conditions are not only more likely to not to be traumatic, but also are disproportionately experienced by people of color and other marginalized or oppressed groups. So when you think about like the demographics of your staff or potential staff that you want to join and come and work at your company, that's just another thing that we want to be really clear. It is both prevalent, so it impacts a lot of your staff, and it's also an equity issue in that some groups are more likely to experience trauma. So that's kind of our grounding and kind of a question I want y'all to ask yourselves, or just pause. You don't have to answer out loud. But what do you know about how trauma impacts your employees? Not necessarily that you need to know like how many people or which people at your organization have a trauma history or anything like that, but just generally speaking, if we know some folks inevitably at your company have had these experiences or are currently experiencing sort of toxic stress, like how does that impact them? How does it show up at work? What do you know about that? Here's what we've observed at the National Fund and in our work is that there are ways it shows up in how staff perform, their job satisfaction, kind of looking back at the job design framework that Tom shared at the front. You know, there are kind of these elements of what makes up a good job where if you've experienced trauma, like you really need to have that lens to figure out what's going to be most supportive for folks in those positions. And we also know that like being trauma informed doesn't just benefit people who have experienced trauma, it benefits all of our workers. So here's just, I'm not going to go through this slide in detail, but just to illustrate that there are sort of business outcomes or performance issues that kind of underneath them, if you start like looking underneath the behavior or the problem, you can see how an experience of trauma might impact that. And kind of understanding that is really helpful for figuring out like, well, what's the solution? Because having this understanding might influence how you think about what an appropriate solution might be. So another cute animal picture. These are baby sloths. So what does it mean to have a trauma-informed workplace? We just know that trauma-informed workplaces prevent traumatization and re-traumatization and promote resilience for all workers. And I'm going to share, this is a framework or a way to think about what are the elements of being trauma informed. So these are 6 principles that come from the Substance Abuse and Mental Health Agency, SAMHSA, and they've been used in a lot of different settings, like social support settings. And I want to just take a second and think back on kind of some of the examples that Cooper shared from the work that they've done with rapid cycle process improvements, and think about your own organization and how understanding some of these principles might be helpful. So a couple things, so I'll give an example of something I heard Cooper say. He said, trust is really critical. And so how do you start to build? So trust is important for everybody, kind of that psychological safety to feel like if I tell you what I think, are there going to be repercussions? So at a basic level, that's why trust is important. Now, if you think of someone who has had experiences with gender-based violence or experience in which sharing an honest truth about something did not yield someone responding to what they shared, but actually yield like harm from being honest about what you thought, it's even more important that these employees feel like there's a place for trust. They can share it without repercussion and feel like someone's actually going to respond to them. So building that trust requires listening to what employees want and then responding to what they want. So you're actually demonstrating and showing like, not only are we listening to you, but we're like going to actually act on what we heard you say. And that kind of builds trust. The voice and choice. Well, actually, I'm going to pause and see if anybody, Cooper, if you want to jump in, or if anybody else heard an example that kind of maybe aligns with one of these principles.
I mean, I'll jump in and say, I think the practice, and this may align with the example you're about to give, Carrie, but the practice at Duke of having the frontline employees actually take leadership over the huddles is a way of, I mean, they had to get through this kind of painful growing period, but it is a way of like both creating kind of this collaborative and mutual helping atmosphere, but also establishing kind of deeper trust and transparency about how decisions are made.
Mm-hmm. Absolutely.
We even made at the executive level, for the longest time, I ran the huddles. And at some point I said, well, why am I running the huddles? I mean, what inherently makes me better at running these huddles than anybody else? And then from an organizational resiliency, how is it preparing anybody else to do this? And so we now rotate it every week. We have an administrator on call, and whoever's the AOC runs the huddle. Everybody's in charge at some point. And we've found some real creative ways of doing it, because not everybody does it the same way. Some of those people's ways work better than mine did. And so it's giving people room to grow.
Yeah. I think
Don't
just
take the
this
fear out of it.
Yeah, I think that, and the example I gave of, you know, when you think about folks who may be coming into some of these positions, especially if you're focusing some of these improvements on frontline workers or entry-level positions, and folks who this may be, they may be coming from backgrounds in which they don't really know how to take that leadership role. They don't know how to share their voice, because it's always been met with kind of a negative response or a harmful response, and they've learned these ways to protect themselves and survive. If you imagine giving folks space where they can trust that and they can actually grow those muscles and practice that skill at work, that can be a really healing process for folks, that they can do that at work, and they can then start to do that in other areas of their life. And so I just want to help bring that picture that, like, having voice and choice and space to grow for anyone in your organization is going to be positive for them and for the organization. And even more so for folks who have have this background. It can be actually healing and like super helpful for their own mental health and well-being. And the other thing I just want to say is, as you're hearing from folks about what their problems are, where their issues are, you may hear more explicitly something that triggers for you, like, oh, this is like, you'll have this lens and you can say, this will be particularly harmful or a particularly problematic issue for folks on our staff. I may not know who they are, who I know have a trauma background, or who I know are experiencing a lot of stress outside of work. And you'll start to kind of say, like, okay, well, this is going to be a priority issue for us, or we're going to approach this with a different lens, or I'm going to go look for another expert to help me think through how to solve this particular issue that our staff is experiencing, because I kind of understand what might be going on under the surface. So thank you for sharing those examples. And I think there's 100 different ways that you can start to use these principles to check yourself, like, as you're going through these processes and you're hearing things that need to be improved, or things you want to try. You can kind of use these principles to say, all right, how might this impact folks who have experienced trauma on our staff, and how can we use these principles to inform how we move forward?
Carrie, I have a question, or maybe just a comment with what Cooper was talking about earlier. When I look at the transition here, or just the list of principles, and collaboration and mutuality, peer support, those things kind of in the middle there. I'm wondering, Cooper, if as you guys went through your process and you began to experience how things were becoming more effective and changing, when you began onboarding for new people, as you brought new people on, did you give them that peer support or match them up with a buddy who was part of the program so that their onboarding would go? I mean, I know you talked about a 6-month onboarding process, which I think is, or a longer onboarding process, which was great, but did you also connect them with peer support?
So part of that was establishing some preceptor roles in what you can call peer support. I call it any, but someone who is seasoned with someone who is new. And then we instituted some other things. We also made sure that the senior clinical person in our organization, who's our senior director of clinical ops, and our staff all have our personal cell numbers. And we'll say, you're giving that out, people are going to call you. Well, that's kind of the idea, right? I mean, they're going to call you night and day. Well, first of all, they don't call night and day. And when they have called, it's because there was really a need. And so our senior director of ops actually has a white flag, a little garden flag, like you'd see to mark a utility line in your yard or something like that, just a little white flag. She has it put in the welcome pack for every employee. When she walks in, she goes, everybody reaches a point that they want to give up. When you need help, this is your white flag. And I'm expecting you to wave it because I'm going to wave mine.
Mhm.
And the idea is that everybody's job is to help. It's not just your preceptor. It's not just your supervisor. And if you don't know who to call, she'll say, if you don't know who to call, you call me and I'll help you solve it. I may not be the answerer for you, but I'm going to help you find the person that can answer. There's not a wrong door. You don't have to be afraid to ask. And if you've asked a question 7 times and you don't know the answer, it's not because you're dumb. It's because we didn't teach it the right way.
Mhm.
We've got to take the 4-letter F word out of the workplace, which is fear. The other word sometimes has to be used behind closed doors.
I was gonna say, don't take that one out.
Well, no. That one is on occasion. It's held in reserve. But we've got to take fear out of the workplace. And I'm not familiar with. This was the first time I'd seen the trauma work that Carrie was teaching about. But I wish I'd seen it earlier because it is so spot on.
I was just thinking about the application of it and thinking about what you guys did and the application of these principles.
And that, thank you for your question, because you're just demonstrating how already you're using the lens. You're already trying to take the principles and think about how you might. That's a great thing to try, right? Is like, let's try a peer support. Let's see how people like it. If they don't like it, let's see how we can improve how we connect people with peer support. And I think it just provides a little bit more guidance when you run into a challenge, and you hear a problem that you don't have an immediate solution to, or folks would like more support, figuring out how to, well, maybe try some peer support, or maybe, and I know we're at time, but I really want to get to the example before I hop off. So this is not a healthcare example. This is actually from a hotel chain. Atelier Ace Hotels. They have hotels across the country and some internationally, and they worked on a job quality project with the National Fund, and they wanted to really focus on the impact of trauma on their housekeeping staff and other frontline employees. And really, because this started during the pandemic, and the hospital industry, as we all know, the hospitality industry was really impacted. A lot of folks were worried about their jobs and also worried about, similar to healthcare, exposure to COVID. And it was really hard on a lot of their staff. As they started to come back to work, that stress, it was just really hard to figure out, how do we continue to support our folks around the stress they continue to feel at work and outside of work. And then sort of related to the pandemic, and sort of just by circumstance, there happened to be several acute instances of folks who had died on staff, like a part of the staff, or some other really traumatic experiences that were very acute that the staff was experiencing, and they were trying to figure out how to respond to. And so they, through some coaching and support, learned about different ways, kind of like I started out with this 4x4 breathing. Like, what are some things you can do to kind of like help folks figure out how to manage the impact of when they get triggered, or when that past trigger shows up at work and you're on the job? How can you help mitigate that? How can you help each other? And how can your managers and supervisors provide you with support on the job so you can continue to do your job well? So this is what they did. They have like a daily huddle, a version of the daily huddle for their housekeeping teams and different teams on their staff and their group. And they started implementing this quick check-in where they talk about the regulation curve and how throughout the day we can feel in the gray zone, the green zone, or the red zone. And they just would do a quick check-in and say, like, ask folks to voluntarily share where they are on the regulation curve that day. And the manager leading the huddle would also share. In addition to this, they provided, the organization provided resources and tips. So you can see they have this sort of like internal, on the right side, this internal communications tool where they would share, like, they called it being your best, tip 1, tip 2. And it all was about like how you regulate what's going on with you or what you're bringing from outside work into your job to kind of help manage those feelings. And it did a number of things. Well, first of all, they didn't use the word trauma or mental health anywhere in any of this. They called it being your best because they didn't want it to focus on, we're doing this because we want you to improve your performance. They really wanted to focus on, this is to support you all because we care about you, which I think was a really important intentional choice. But it normalized kind of like, hey, we're human beings. We are not just like hospital or hotel worker robots. We have things that are going on in our lives, and inevitably we all are going to bring that stress to work with us. This is a space where we can help each other, that peer support, that mutuality, that safety and trust, work through that stuff so we can do our jobs well together, and we can enjoy our jobs and not have our jobs be another source of that kind of stress. And so they just, there was an overwhelming positive response to rolling this out. They want to kind of roll it across more of their hotels, particularly from the supervisors who often experience the other side of their workers' stress, which was like when you don't talk about it, when you don't have any way to support them, it comes out in other ways, right? It comes out in conflict, it comes out in performance issues. And so they were really happy to have just any kind of tool or intervention to use. And so they're documenting their lessons learned and continuing to improve how they roll practices like this out. So that is my presentation. I have maybe a couple of minutes to stay on if anyone has any other questions.
Since I know Carrie does have to run soon, though, can I ask everyone who is left, just give us a little round of snaps for both Carrie and Cooper? Really appreciate you two joining us today. But yeah, if there are any further questions, please share them now.
I have one question. So I work remotely, and so I know a lot of, in today's world, there's a lot of remote work, even in healthcare and healthcare administration and leaders and things like that. So how does the ability to implement this, how does remote working factor in to the ability to implement this? Because a lot of it can be done face to face, and I think sometimes for me, face to face makes it better, but to the challenge of remote conversations or having them reach out to you in that way.
For both of us, for Cooper and
yeah, for both of you, actually, Carrie,
yeah.
for you especially, because I think with a lot of the pieces that you've put in there, I think sometimes having those hard conversations or having somebody actually feel empowered from a remote perspective is a little bit more difficult.
So I think that's a great question. And I understand where it comes from, because I think a lot of that, especially folks who have been in certain kinds of gender-based violence or situations where you do have to read people, you're used to like reading people's body language to kind of understand if this is a safe situation or not. And building or trusting relationship oftentimes can, there's something about being in person that helps facilitate that. At the same time, there's a lot of ways in which being remote builds in a sense of safety. It allows people the ability to kind of turn their cameras off or like go on mute or kind of be in a safe space where they are. So I do think there's some opportunities to kind of build on, and there may be some sort of like positives being remote in terms of how you build that relationship and rapport and build that trust. And so kind of using tools using technology, leaning into technology and exploring like, and kind of to the rapid cycle feedback loops of like, how does it make y'all feel when we send messages on our app or on our little tool versus in a meeting like this when we're all on Zoom? And you might be surprised how many people are like, I really like getting the little bits of information versus like having to turn my camera on. Or so I think for a lot of folks, the remote maybe offers some more kind of safety and opportunities for building trust.
Maybe an opportunity to let people have their choice. Yeah.
Okay, I do have to hop off to the other call now, but thank you all. This was a really fun chatting. Tom, of course, has my info if you want to chat more.
Thanks so much, Carrie.
So Annette, one of the things you asked was about the in-person versus the remote. And one of the things that we found is that because we often have a remote workforce because they're working from their cars or going to patients' homes, we found that, and this was tough for me because I'm an in-person kind of guy. Okay, I like the in-person, and folks were saying, yeah, but in-person is great for all of y'all that are in the office. And what it became was a division between those in the office and those that were out on the road or at home. And the idea was not to create a two-tiered experience. The idea was that everybody was going to have the same experience. And what we ended up doing was we took all of our tiers, not all of our human interaction, but all of the tiers that we use, tier 1, 2, and 3, are all now remote. Actually, tier 4 is too, which is a system-wide one. It's totally remote. And when we first started doing this, I was like, oh my gosh, now it's just, we're going to be heads on screens. Well, we're on a level playing field now by doing it. The second is I can now, and any of our leadership can now attend frontline tiers that they normally couldn't physically get to. And you know, so I can check in, because we're 15 minutes, I can check in here and check in there, and I can get a real pulse of what's going on from our staff. The other part that's an unintended consequence is if you think you're frustrated in your job, go hear about where the work really gets done by our frontline staff. It'll remind you why you're doing the work. I did not come to work when I was a little boy. I did not dream of fighting with insurance companies. That was not what I wanted to do. There was a chance at playing pro baseball, except I was not talented, but I wanted to. But I never really want to fight with an insurance company. That was never the real glossy job for me. But I get to hear the work of where we touch people's lives from the people that are doing it. And you're also hearing the frontline challenges they're having, safety issues. I mean, we just made a change this past week in a safety practice that came up because a frontline staff member said, I know we've done it this way for years, but I don't think the communities we're doing it in are the same way they were years ago. And we need to make a change because it's not safe for our staff. So we pulled a work group together and looked at it. We found out that what she said was exactly true. And thankfully, she felt she could bring it up because now the risk profile of our work has gone down because we've made a change in the way we do practice because our frontline staff brought it. And that was last week. I would have never known that was a problem. It's been going on for in my tenure here, 5 years, I never knew it was a problem until a week ago.
Wow. Yeah, sometimes the worst answer to a question is why do we do it this way? And it's because that's how it's always been done. I think that's,
Right.
it's just not. Yep.
I'll just add, I mean, there is, with a shift to remote and now some of the shift back, like people realize that there's a magic in some ways to in-person communication. Yeah. That can happen sometimes, and that's valuable. But I would say the deeper magic is communication itself. And part of what Cooper is getting at here is that the tools we have now can enable more communication and kind of more check-ins, more ability to really kind of have those opportunities to build trust. And that's something that is inherently valuable, like no matter how you do it. So Cooper has offered to stay on to answer questions if people want to continue talking. If you want to have full time back in your day, you're welcome to. I did want to call attention in the chat to our next two Frontline Focus events. We have our next webinar, which is going to be June 8th. We're taking a week off for Memorial Day. And that's going to be focused on really kind of more pipeline building topics, how you build equitable pathways. And some of that's going to focus on skill building. Some of it's going to focus specifically on second chance hiring as a practice. And then we have an in-person meeting in Washington, D.C. that we're excited to announce. It's going to be July 18th, 19th at the National Fund offices. A lot more information will be shared about that soon, but Claudio has shared the registration page. And we know some of you are still under travel restrictions, but we'd love to see you there. If you think you can work it out, please let us know. Are there any other questions for Cooper, or just things that are bubbling up for those of you who are left on the call that you'd like help thinking about? Thank you, Edwina. Well, if not, thank you again, Cooper, for joining us as our guest today. It's been great having you here, and happy to give you all some time back in your day. Thank you for your support of CareerStat and for joining us this week.
Thanks for letting me join you. It's really been a privilege and an honor. It's been a great conversation.
Thank you.
Thank you, everyone. Enjoy the rest of your day.
Bye.